Hello everyone, I am myself Dr. Rajesh Gubba. I am the general medicine educator. So in this session I will be discussing a very important topic in the neurology, that is the Friedreich's ataxia. So Friedreich's ataxia, let me tell you, it is an inherited disorder, right? And what type of inheritance is this? It is an autosomal recessive type of inheritance. And this Friedreich's ataxia, it is mainly due to gene mutation. So you see this question. Friedreich's ataxia is caused by which type of mutation? Point mutation, expanded trinucleotide repeat, missense mutation, inversion. So if you take this, alright, we will discuss and come back to this question once again. So Friedreich's ataxia, let me tell you, it is an autosomal recessive disorder. Right, it is an autosomal recessive disorder. And another name for this Friedreich's ataxia or Friedreich's ataxia is a type of spinocerebellar ataxia. Right, Friedreich's ataxia, it is a spinocerebellar ataxia. Now, this particular Friedreich's ataxia, as I have said you, it is due to gene mutation. And you need to know what is the gene which is being mutated and as well as on which particular chromosome that particular gene is located. So, this Friedreich's ataxia, it is caused by loss of functional mutation in the Frataxin gene. Right? So, the gene which is being mutated is the gene which is being mutated is the Frataxin gene, and this Frataxin gene, it is present on the chromosome 9. Right, it is present on the chromosome 9, and majority of patients, they have, now what type of mutation is this? It is an expanded trinucleotide repeat. Right, the type of mutation is expanded trinucleotide repeat. Okay, so that is the type of mutation that you will see in case of the Friedreich's ataxia. And this expanded trinucleotide repeat, it is in the intron 1 of both alleles of the Frataxin gene, right? Within the Frataxin gene, you have intron 1. So, the trinucleotide repeat, it is in intron 1 of both alleles of the Frataxin gene. Now, what is that particular trinucleotide repeat? So, as I have said you, this disorder type of inheritance is an autosomal recessive type of inheritance with trinucleotide repeat, and it is caused by expansion of a poly-GAA locus. Right, expansion of poly-GAA locus in the gene for Frataxin on chromosome 9. Right, and what is the age group at which you will have the clinical features in these patients with the Friedreich's ataxia is, the clinical features, they are usually seen in the childhood or early adult life. Right, in the childhood or in the early adult life, you will have the onset of clinical manifestations in these patients with the Friedreich's ataxia. So, you see this question now, Friedreich's ataxia, it is caused by which type of mutation? Point mutation, expanded trinucleotide repeat, missense mutation, inversion. So, it is an expanded trinucleotide repeat, right? And what is that particular trinucleotide repeat? That is poly-GAA, which gets repeated. And we have few more, I'll tell you that. Now, you see this. Friedreich's ataxia, I said you, it is a subtype of spinocerebellar ataxia. And you need to know what is the most common type of ataxia in India. Spinocerebellar ataxia type 1, 2, 3, 4. So in India, the most common form of spinocerebellar ataxia is SCA type 2. Right, it is SCA type 2 that is the most common form of spinocerebellar ataxia in India. And all over the world, if you see, it is spinocerebellar ataxia type 3 which is the most common spinocerebellar ataxia in the world. Whereas in the southern parts, the most common form of spinocerebellar ataxia is spinocerebellar ataxia type 1. So these are the most common forms of the spinocerebellar ataxia. So the one which is more common in India, it is the spinocerebellar ataxia type 2. Now, if you take the Friedreich's ataxia and as well as the other spinocerebellar ataxia, so in the differential diagnosis for Friedreich's ataxia are the other spinocerebellar ataxias, right? Your Friedreich's ataxia, it is a subtype of a spinocerebellar ataxia. So the differential diagnosis for Friedreich's ataxia will be the other subtypes of spinocerebellar ataxia, right? And we have totally 30 types of spinocerebellar ataxias, right? We have totally 30 types of spinocerebellar ataxias, okay? And these spinocerebellar ataxias, they exhibit autosomal dominant inheritance pattern. Whereas Friedreich's ataxia, it is an autosomal recessive type of inheritance. And in autosomal dominant type of inheritance pattern, what is that particular trinucleotide repeat is? It is poly CAG expansion. Right, it is poly CAG expansion of the affected gene. That is what is seen in the other forms of the spinocerebellar ataxia. Now if you see the Friedreich's ataxia, it is an autosomal recessive, right? What is the repeat there? It is poly GAA. Whereas in case of spinocerebellar ataxia of autosomal dominant type of inheritance, the repeat is poly CAG expansion, right? Now you see the manifestations of the Friedreich's ataxia. So the question is like, what is the earliest presentation of the Friedreich's ataxia? Ataxia, seizures, optic atrophy, stuttering. Now let me discuss and then come back to this question again. So before discussing the clinical manifestations, you need to know the pathology. So in the pathology, you need to know which particular part of the spinal cord is being affected first, right? Which part of the spinal cord is being affected first. So in the pathology of the Friedreich's ataxia, involvement of dorsal root ganglion is the first major abnormality. Right, involvement of dorsal root ganglion. Right, that is the first major abnormality which is seen with the Friedreich's ataxia. Now you see, this is the dorsal root ganglion, right, through which the sensory nerve or the sensory root enters into the dorsal horn. Now following this, what are the other structures being affected in Friedreich's ataxia? The other structures which are being affected is degeneration of corticospinal tract, right, degeneration of corticospinal tract. And the second important structure which is being affected is degeneration of posterior columns, and the third important structure which is being affected is degeneration of spinocerebellar tract, right? Degeneration of spinocerebellar tract. And the fourth important structure is the degeneration of the peripheral nerves. Right, so these are the structures which gets affected in these patients with the Friedreich's ataxia. But what is the most common and the first structure which is affected, that is dorsal root ganglion. Now let me tell you the clinical features. The clinical features, they are mainly because of the involvement of these particular structures, and out of which the peripheral nerve involvement and as well as the post spinocerebellar tract involvement, that we make the individual to develop ataxia. Right, as the name itself tells you, it is ataxia, Friedreich's ataxia. Ataxia of the gait, that is the initial symptom. Right, ataxia of the gait, that will be the initial symptom. Now, if you take this ataxia, what exactly is this? It is imbalance while walking, is what is called as the ataxia. And this particular ataxia, what is the type of ataxia you will have? There is peripheral neuropathy and there is also spinocerebellar tract involvement. So the ataxia, it is of mixed right, it is of mixed sensory and cerebellar type. Right, it is of mixed sensory and as well as the cerebellar type. Now in these patients, they cannot balance themselves if they stand normally. Right, if they stand with the feet together, they cannot maintain the balance. So in order to maintain the balance, what they try to do is, the patients, they stand with feet wide apart. Okay, so these patients, they stand with feet wide apart. Okay, why? That is mainly to maintain the balance. Right, now in these patients, because of the involvement of spinocerebellar tract, the Romberg sign is positive. Right, so what do you understand by this word Romberg sign? So the individual is asked to maintain, this is mainly to test the intactness of the cerebellum. So what the individual is asked in this Romberg sign is, the individual is asked to stand with legs together with eyes closed. So first, initially with legs together, eyes open, he should stand and maintain the balance. And if he is able to maintain the balance with eyes open, then later the next thing is, he is asked to stand with legs together and eyes closed. And we need to check whether the individual is able to maintain the balance or not. And for suppose, with eyes closed, with standing with legs together, if the individual is swaying, right, the individual is not able to maintain the balance, then that we consider to be Romberg sign is positive. Okay, and these individuals, they also have dysarthria. So why do you think they have dysarthria? That is due to difficulty in articulation of the speech. Right, what is the dysarthria? Dysarthria is difficulty in articulation of the speech. See, cerebellum is a very important structure which is required for the coordination of the muscles of speech, right, and it requires the coordination by the tongue muscles as well, and it requires the coordination by your laryngeal muscles as well. So once there is cerebellar involvement, there is difficulty in articulation of the speech, and that is what is called as dysarthria. And these patients, they also have dysmetria. Right, they also have dysmetria. So dysmetria is that where the individual is unable to reach the target properly. Right, either the individual is, like, it is nothing but how do we test dysmetria? That is by doing finger nose test. The individual is asked to touch the finger of the examiner and nose of himself, and whether when he is able to do that, then the individual is supposed to have the normal coordination. Right, that is finger nose coordination is present. But if the individual is not able to do, the individual is able to touch the examiner's finger, but he is unable to reach his nose, either he is undershooting or the overshooting. That is what is called dysmetria. And another important feature of the cerebellar involvement is nystagmus. Right, and this particular nystagmus, it is the horizontal nystagmus. right? It is horizontal nystagmus where there is to and fro movement of the eyeball. That is called nystagmus. So these are the clinical features that you will come across in patients with the Friedreich's ataxia. Now, apart from that, these individuals with Friedreich's ataxia, they also have the associated features. And these particular associated features include, you can see the arch of the foot, right? It is a high arched foot. And this we call it as the pes cavus. Right, this we call it as the pes cavus. And if you take the spine of these individuals, there is forward bending of the spine and as well as even lateral bending of the spine, and that we call it as kyphoscoliosis. Right, that we call it as kyphoscoliosis. And these individuals, they also have the muscle weakness, and that is what is called cardiomyopathy. And this particular cardiomyopathy, it is seen in almost 90% of individuals, and the type of cardiomyopathy that is seen in patients with the Friedreich's ataxia is they develop dilated cardiomyopathy. And these individuals, almost in 20% of individuals, they develop diabetes mellitus. There is also involvement of the optic nerve, that is optic atrophy. And finally, the individuals will have impairment of memory, and that is called dementia. So these are the associated features of Friedreich's ataxia: pes cavus, kyphoscoliosis, dilated cardiomyopathy, diabetes mellitus, kyphoscoliosis, optic atrophy, and as well as the dementia. Now, so if you see this question now, the earliest presentation of Friedreich's ataxia, what will be the answer? It is the ataxia. That is the earliest presentation. Now I'll just ask you one important question. Absent ankle jerk and extensor plantar response is found in Friedreich's ataxia, tabes dorsalis, subacute combined degeneration of the spinal cord, vitamin B1 deficiency. So you have to understand that absent ankle jerk, it is the feature of lower motor neuron lesion. Right, it is the feature of the lower motor neuron lesion. Whereas extensor plantar response, it is a feature of the pyramidal tract lesion. Right, it is a feature of the pyramidal tract lesion, right, and it is an upper motor neuron sign. Right, it is an upper motor neuron sign. Extensor plantar response is an upper motor neuron sign, that is corticospinal tract involvement. Pyramidal tract is nothing but corticospinal tract involvement, and absent ankle jerk is a lower motor neuron sign. So absent ankle jerk and extensor plantar response, where is that you have? See, this particular feature is unique in case of the Friedreich's ataxia. So the unique feature of Friedreich's ataxia is that despite involvement of corticospinal tract, there is abolition of the tendon reflexes. And this particular unique feature definitely requires the further elaboration as well. So because of the corticospinal tract involvement, they will have spasticity, and there is also presence of the Babinski sign. Right, there is also presence of Babinski sign. But the deep tendon reflexes, they are abolished or they will be absent. Now the question is, why these deep tendon reflexes are absent in this individual? Now I have said you that in patients with Friedreich's ataxia, there is also involvement of the peripheral nerve, and there is also involvement of the dorsal root ganglion. So due to peripheral nerve involvement, right, due to peripheral nerve involvement, and as well as the involvement of dorsal root ganglia is the one which will make the individual to have absence of the deep tendon reflexes. So abolition of tendon reflexes, that is due to the dorsal root ganglia and as well as the peripheral nerve involvement. So answer to this question, absent ankle jerk and extensor plantar response is found in the Friedreich's ataxia. And you will come across even in patients with subacute combined degeneration of spinal cord due to vitamin B12 deficiency. Even that I will discuss in the next session. The next section I will discuss about the vitamin B12 deficiency associated neurological manifestations. Now in these patients, you need to know what is the most common cause of death in patients with Friedreich's ataxia. The most common cause of death in patients with Friedreich's ataxia, let me tell you, it is mainly the cardiac disease. So I said you cardiomyopathy, right? And what is that cardiac disease? It is the dilated cardiomyopathy. So I said you like cardiomyopathy is seen in almost 90% of individuals. And what type of cardiomyopathy is that? It is dilated cardiomyopathy. And this dilated cardiomyopathy is the one which will make the individual to have the development of heart failure with reduced ejection fraction, right? And heart failure with reduced ejection fraction, where the ejection fraction will be less than 40%, that will make the individual to have the death. And these patients with the dilated cardiomyopathy, they are also more prone for the development of the arrhythmias, right? They are also more prone for the development of the arrhythmias. So heart failure with reduced ejection fraction and as well as the arrhythmias, they are very common in these patients with the Friedreich's ataxia. Then followed by that, what are the investigations that you need to do in Friedreich's ataxia? So in the central nervous system, where is that you will observe the changes, right? In the central nervous system, the changes are conspicuous in posterior and lateral columns of the cord, right? In the central nervous system, the changes, they are seen in the posterior and as well as lateral columns of the spinal cord. Right, posterior and as well as lateral columns of the spinal cord. And the electrophysiologically, right, electrophysiologically, conduction velocity in motor fibers is normal or only mildly reduced. Okay, conduction velocity in motor fibers right, either it is normal or it is mildly reduced, but the sensory action potentials are small or absent. Right, sensory action potentials, they are small or they are absent. That is what is the electrophysiological studies that you do or that will be seen in patients with the Friedreich's ataxia. And finally, how do you treat these patients? Let me tell you, it is a genetic disorder, right? So there is no specific drug to reverse this particular disease. Only supportive therapy has to be given. Right? For example, the individual developing dilated cardiomyopathy, you need to give the beta blockers and as well as ACE inhibitors, or you need to give the angiotensin receptor blockers, that is valsartan plus the secubitril plus valsartan, which is nothing but your ARNI, that is angiotensin receptor neprilysin inhibitor. So supportive treatment is required depending upon the symptoms, right? Whatever the symptoms are there, you treat that particular symptoms, right? And another important thing is, in order to improve the muscle strength, physiotherapy has to be done, right? So these are the clinical these are the treatment options or the treatment that you need to do in patients with the Friedreich's ataxia. So Friedreich's ataxia, it is a form of spinocerebellar ataxia. It is mainly due to mutation of the gene, that is Frataxin gene, which is present on chromosome 9, right? So with this, I'll wind up this very important session, that is Friedreich's ataxia. Thank you very much.